So hello class, welcome to the last part of our lesson for today on disorders of the hypothalamus and the pituitary gland. So for this part of the lecture, we're going to discuss the disorders of the neurohypothesis or your posterior pituitary. Here we're going to discuss diabetes insipidus and SIADH. We will skip the hypodipsic hypernatremia, not very common anyway. So your disorders of the neurohypothesis will involve your vasopressin and your oxytocin. And as a review, remember you have two nuclei involved in the secretion of your vasopressin and your oxytocin. I have this in my other slide. So your paraventricular nucleus is involved in the secretion of is the nucleus that synthesizes, no? Synthesizes your oxytocin. And your oxytocin now travels down your pituitary through your axons, no? And it is in the posterior pituitary where your oxytocin is released into the systemic circulation. On the other hand, your vasopressin comes from your supraoptic nucleus. No? Your supraoptic nucleus synthesizes your vasopressin, and your vasopressin likewise travels down the axons to the area of your posterior pituitary and release into the stimulation. So anything that will affect or compress or disrupt the stalk, no, can affect your oxytocin and your vasopressin levels. So let's go first to your vasopressin. So your vasopressin has many names. It's also called your arginine vasopressin or AVP, or its old name. Its old name is antidiuretic hormone, and it is regularly regulated primarily by the effective osmotic pressure of the body fluids. So this is mediated by the osmoreceptors in the hypothalamus. So you have osmoreceptors in the hypothalamus, and the osmoreceptors are sensitive to any small changes in the plasma sodium. So if there's any changes in the plasma sodium, it will now send a signal to your hypothalamus whether to increase synthesis or decrease synthesis of your vasopressin. So when your your arginine vasopressin is suppressed, no, you will have water diuresis. Remember, because this has an antidiuretic effect. So if you suppress antidiuresis, you will have, of course, diuresis. So vasopressin synthesis and secretion is stimulated by these factors. So your vasopressin acts by reducing water excretion in the collecting ducts by promoting the concentration of your urine. No? In the absence of your AVP, the cells in the collecting ducts are impermeable to water and reabsorb little. So therefore, the resulting effect will be a large volume of dilute filtrate. So since the water cannot be reabsorbed because it's impermeable because of the lack of your vasopressin, the urine will become voluminous, and there's lots of water there, so it's very dilute because the water cannot be reabsorbed because of the impermeability caused by the lack of your antidiuretic hormone. Okay, here. So if there is presence of your vasopressin, the cells in the collecting ducts become selectively, no? Meaning it will only allow water to be reabsorbed. No? So water will diffuse back, be reabsorbed, and now the urine will now become concentrated. Okay, so that's how your vasopressin works. So how does vasopressin do this? So your vasopressin attaches to your V2 receptor in your collecting duct. So this is your collecting duct. So in the epithelial cells of your collecting ducts, there is your V2 receptor in the basolateral side of the epithelium. And this, once it attaches, it sends signals, no, for the aquaporin vesicles to fuse its membrane with the luminal side of the basal of the epithelium in order for the aquaporin channels to attach to the wall. Now, the aquaporin channels will now facilitate the reabsorption, the selective reabsorption of water into the cells and back into the circulation. So this is how your antidiuretic effect of your vasopressin regulates urine volume. So this is how the urine volume changes. No? Okay. So what happens if you have defects in your vasopressin? So then you will develop a condition called diabetes insipidus. No? Diabetes insipidus has two types. You have your central diabetes insipidus and your nephrogenic diabetes insipidus. So what happens? This diabetes happens if there is a decrease of 75% or more in the secretion of vasopressin. So if your vasopressin is only decreased by about 25-50%, you still won't manifest the diabetes insipidus yet. No? Especially because we also have preformed vasopressin. No? It's not depleted right away. But once it reaches deficiency of 75% or more, then that's the time that you will have diabetes insipidus. No? If you lack vasopressin, you will have central diabetes insipidus. If you have hormone resistance to vasopressin, meaning the kidney is not responding to the vasopressin cannot act on the kidney. That's what we call nephrogenic DI. And what happens in diabetes insipidus? There is a production of abnormally large volumes of dilute urine. So if you've had patients like this, you won't forget it. Because this patient, you will see in the urine bag, no, suddenly, all of a sudden, in an hour, there's half a liter already of urine in the bag. Usually, sometimes, no, you can panic because, oh my God, there's a lot of urine. Patient could be massively dehydrated. Okay? And usually dilute, meaning almost clear. The color of the urine is almost clear. No? And this is also characterized by urinary frequency, enuresis, no? Involuntary urination, nocturia, which may disturb sleep, thirst, and commensurate increase in fluid intake. So, what happened normally? So, in central diabetes insipidus, your posterior pituitary is unable to supply the body with enough vasopressin. So, your urine, the water in the kidneys is not reabsorbed. So, you have a dilute urine. Compared to this is concentrated urine. Okay? So how do we diagnose? The 24-hour urine volume is more than 50 ml per kilo body weight. So if your patient is 50 kilograms, that's more than 2.5 liters per day. And the urine osmolality is less than 300. Sometimes you can indirectly check that with the urine specific gravity. What are the causes? I mentioned earlier, central DI, usually it's coming from the pituitary or your hypothalamus. Gestational diabetes insipidus, your vasopressin is metabolized prematurely, no, by the placenta. So if the vasopressin is metabolized prematurely by your placenta, you will have low vasopressin levels. And you can also have primary polydipsia. The patient just wants to drink a lot water. No? So polyuria results in small decrease in body water, increase in plasma osmolarity and sodium because of the dehydration. Because you lose water, there is a slight increase in plasma osmolarity and a corresponding increase in urine osmolarity because of the dilution. And because of this, it stimulates thirst and you will have a compensatory increase in water intake. You'll feel thirsty. Sometimes, if you're not able to drink enough water, and you continue to lose water in your urine, no, these patients can develop hypernatremia and dehydration. No? So in most patients, if it's just mild diabetes insipidus and the patient is able to drink water, no, hypernatremia and dehydration do not develop. No? Okay. So sometimes what we do in patients with diabetes insipidus, during the day, we ask the patient to just drink lots of water. No? Every time he urinates, drink water. But at night, that's the time we give the desmopressin, so that he won't have to get up in the middle of night just to urinate, because it really makes them sleep deprived because of the frequent urination at night. So how do we diagnose? We have symptoms of diabetes insipidus without glucosuria. Sometimes the glucose in the urine can cause osmotic diuresis, so that's not diabetes insipidus. And then we do a 24-hour urine collection and ad libitum fluid intake, and check for if the urine volume is more than 50 ml per kilo per day and the urine osmolarity is less than 300. Now, if you're able to confirm diabetes insipidus, we now determine whether this is central or nephrogenic DI. And by doing this, you just see what the clinical setting of the patient. So, for example, the patient has had pituitary surgery, so most likely this is central DI. Or the patient had history of, let's say, traumatic brain injury, so most likely the cause of the DI can be central in origin, so central DI. So as I mentioned earlier, the type of DI can sometimes be inferred from the clinical setting. So some other with nephrogenic DI, on top of my head, the things that I can remember would be the intake of lithium. Lithium can have a side effect of nephrogenic diabetes insipidus. So a confirmatory test is to determine the effect of fluid deprivation and injection of ADH. So you try to do water deprivation test. You ask the water not to eat, and then you weigh the patient, and then you inject synthetic ACTH and check the effect on its urine osmolarity. So once you've diagnosed a patient, so how do we diagnose? How do we differentiate if it's not clear cut? First, you establish first whether this is nephrogenic or central DI. And then, so this is your algorithm. So if you suspect central, you do an MRI. There's a pituitary bright spot. If it's present, probably your posterior pituitary, represented by your pituitary bright spot, is still intact. But if it's absent, most likely it's pituitary DI. Okay? So how do we treat? If it's central DI, we give synthetic. Since in central DI you lack vasopressin, we can give a synthetic selective synthetic vasopressin called desmopressin, which is specific to your V2 receptor. So it doesn't have vascular effects, because your vasopressin also has blood pressure vascular effects. No? So desmopressin is a selective V2 agonist. In nephrogenic DI, we can give diazide diuretic and low sodium diet, or even prostaglandin synthesis inhibitors such as your NSAIDs. As you can see from this graph, no, at the initial, the intake is very large, the output is also very large, no? Roughly probably 10 to 11 liters of urine output per day. And then after giving desmopressin, you can see marked reduction in the urine volume and a corresponding decrease in the oral fluid intake. Next, we go to your syndrome of inappropriate antidiuretic hormone. So in this syndrome, you have the opposite. You don't lack, or there's no resistance to your vasopressin, but there is an excess, no, of antidiuretic hormone. And here, now you have a decreased effective osmolarity of the ECF this time, meaning the plasma osmolality is low, as opposed to BI, it's high, meaning it's concentrated. Here, the ECF is sort of dilute. No? So these patients can have pseudo hyponatremia or hyperglycemia. So you have to make sure the patient doesn't have pseudo hyponatremia or hyperglycemia, because hyperglycemia can have an effect on the sodium levels. Okay. So in these patients, there will be inappropriate urinary concentration at some level of hypoosmolarity. So these patients would have concentrated urine. Okay, the urine osmolarity is more than 100. It's opposite with your urine, with your diabetes insipidus. Clinically, these patients would have euvolemia, meaning they will not look dehydrated, they will not look hypervolemic, meaning they will not have edema, no, from the excess water retention. No? They usually have clinical euvolemia. They can have elevated urinary sodium excretion even with normal salt and water intake. And you have to rule out the absence of other potential causes of euvolemic hypoosmolarity. It's your hypothyroidism and hypocortisolism and diuretic use. Usually, when we have patients who present with euvolemic hyponatremia, these are our considerations. It's either SIADH, hypothyroidism, adrenal insufficiency, or diuretic use. So first, we can simply rule out hypothyroidism just by doing a random TSH. We can check for random cortisol. And if these are both normal, then we can consider that this is probably SIADH. So how do we treat? So we do Peptan therapy or tolvaptan. These are vasopressin V2, selective V2 receptor antagonists. It blocks the V2 receptor so that the excess ADH will not be able to attach. Sometimes, in some patients, we do limited hypertonic saline administration in order to correct the hyponatremia and urea if it's available. So that's the end of part 6. So this is the end of our whole lesson in disorders of the hypothalamus and the pituitary. So I hope you learned a lot. I know it's a lot to take in. That's why I broke it down into parts. So hopefully you can go back to the parts where you were not able to understand very well. But I hope I was able to explain it as simply as I can. If you still have problems understanding, then of course, I highly recommend reading your book. Okay? Thank you and goodbye.